So I'd like to welcome you all to this IACI webinar on food protein-induced enterocolitis syndrome. My name's Isabel Skiepler. I'm the current chair of the Food Allergy Interest Group of IACI, and I'm just going to start the meeting by just mentioning very briefly a little update on what the Food Allergy Interest Group is doing. So we have three task forces that were approved in November last year. The first one is looking at food allergy and climate change. There are three smaller projects there, looking at vegan foods, unusual food allergens or food allergens in legumes and seeds, and also looking at pollen food syndrome and climate change. The second task force is looking at oral immunotherapy practices in food allergy, and this is led by Felicitas Baluti-Enders. And the third task force is the natural history and new onset of food allergy from childhood to adulthood, and that's led by Bianca Olivieri. So we're being very active. If anyone's interested, wants to find out more about these, do let me know. We'll also certainly be happy to see you all in Glasgow, hopefully. So it gives me absolute pleasure to introduce our first speaker, Dr. Anya Novak-Venjan, who is the Professor of Pediatrics at NYU Grossman School of Medicine and the Director of the Pediatric Allergy and Immunology Division at Hassenfeld Children's Hospital. And I have to tell you that Professor Novak-Venjan was on her way, hoping to be on her way to Austria, but unfortunately, due to a fire at Heathrow, she's still stuck in America. So I'm really grateful to you for giving up your time today and really looking forward to your talk. So thank you very much.
Thank you, Isabel. Let me see if I can share my slides. So I hope you can see it, right? So it is my great pleasure to be presenting today. Thanks to Isabel and the Food Allergy Interest Group of the IACI for that opportunity. I am... I've been always interested in FBIs for a very, very long time, and it's really gratifying to see that more and more people are recognizing the importance of this once very obscure food allergy. I will talk about infantile onset FBIs, which is the most common form of FBIs, and talk about epidemiology, some new triggers, data on prevalence, and natural history. I will touch upon the sort of the conversion from FBIs to IG-mediated food allergy, and then talk about oral food challenges and how the sort of evolving the approach to performing that diagnostic procedure. So it is FBIs. It's classified as a non-IgE cell-mediated food allergic disorder that manifests with predominantly gastrointestinal symptoms that start within an hour to 4 hours after food ingestion, typically 2 hours. And this is different from adults. So Dr. Purificación González Delgado will discuss that difference. And the cardinal symptom is delayed emesis. So delayed, repetitive, multiple episodes, forceful across the room. And in more severe reactions, there is lethargy, pallor, there could be loss of muscle tone. And for some patients, there's a diarrhea that follows within 5 to 10 hours after food ingestion. But it's not all patients, usually associated with more severe reaction and also younger age in my clinical experience. So what's really striking is that there's no typical allergic skin symptoms or respiratory symptoms, no pruritus, no angioedema, hives, or wheezing or cough that accompany those reactions. So frequently FBIs can be misdiagnosed or diagnosis can be delayed because not everybody or like primary care physicians don't really recognize that those could also be allergic symptoms. So FBIs is an allergic emergency. Even though this is a non-Ig-mediated food allergy, reactions can be severe. So some patients may become dehydrated. A subset, probably less than 15%, but there's certainly a risk of a hypovolemic distributive shock. The laboratory findings are non-specific, but there's certainly leukocytosis with predominance of neutrophils. There could be thrombocytosis, metabolic acidosis, methemoglobinemia. Low albumin, low tau protein anemia are usually associated with more chronic symptoms, but in the setting of acute FBIS, there also has been reports of elevated CRP. And then the chronic FBIS does not have the typical, time frame for onset of symptoms. Symptoms are intermittent, and they usually start from water diarrhea, intermittent but progressively worsening emesis, and depending on the duration, they may result in weight loss or failure to thrive, as well as ultimately dehydration and metabolic derangements. So that's why we think FBIS is worth studying, and this is just to illustrate that progressive increasing interest and recognition of the clinical importance, timeline of FBIS, and you can appreciate that, particularly over the past decade, there is significantly more publications in peer-reviewed literature, with a lot of those publications actually coming from Europe. So this is great because it's providing us with different perspectives, different new ideas. And in June of 2022, we participated in the virtual NIAID workshop, so National Institutes of Health, which is also, like a landmark because it does signify that FBIS is an important food allergy problem. This publication also outlined many unmet needs and future directions for research in FBIS. So how common it is? Well, it used to be very uncommon, but more recent studies have estimated that in the US, about 0.5% of children and about 0.22% of adults report physician-diagnosed FBIS. And what was interesting in that study that we've conducted in collaboration with Ruchi Gupta, who is mostly interested in Ig-mediated food allergy, was that those people with FBIS reported high rates of other allergic conditions, such as Ig-mediated food allergy, asthma, seasonal allergies, atopic dermatitis, as well as eosinophilic esophagitis, which sort of puts FBIS, within the spectrum of the allergic diseases, suggesting potentially shared underlying pathophysiology. The estimates from other countries also, fall within that under 1% incidence. So birth cohort studies from Israel as well as from Spain estimates range from 0.3 to 0.7% in the first 12 months of life. The estimate from Australia, which was a different methodology, reported much lower incidence in the first 24 months, but it should be pointed out that 0.015% in the first 24 months was substantially higher than reported EOE or inflammatory bowel disease in the same age range. So it is still much more rare than Ig-mediated food allergy, but certainly it's not a kind of a zebra in the world of food allergies. And FBIS can be caused by any food. I was just recently looking and, adzuki beans, Saccharomyces boulardii, which is not a food, but a probiotic. Similar symptoms could be induced by drugs, by antibiotics. But for food protein-induced enterocolitis syndrome, globally, milk remains the very important trigger. Also rice, other cereal grains like oat, seafood, as well as soy in countries which utilize soy-based infant formulas. So really the dietary patterns in a given population and potentially genetic predisposition or genetic profile may also contribute to particular food triggers as being important in that country. But we are seeing emergence of the allergens in FBIs that traditionally haven't been reported. So, for instance, Japanese researchers, colleagues, report egg yolk FBIs epidemic in Japan, and you can, there's overall increase in FBIs since 2010 to 2019, but compared to milk or soy or wheat or rice, egg yolk has increased dramatically. Similar observations are being reported from other countries. So, for instance, in the US, egg and peanut follow oat, rice, and dairy as top 5 most common triggers. But you can see, obviously, there's a wide range. And also, what's worth pointing out that in pediatric population, majority of infants react to one food or maybe 2 foods. And those that have like really multiple food triggers are quite uncommon, although they're clinically very challenging. So peanut is another trigger that has been very rarely seen and reported before we change our approach to introducing peanut for prevention of Ig-mediated food allergy. Here I'm showing the results or the findings from a large cohort of infants who are introducing peanut in the first year of life in the Netherlands. And this was a large study with 892 infants in the first year between 4 and 12. And the reported prevalence of peanut-induced FBIs was about 0.3% in those atopic infants. So another information that was valuable is that 75%, so 3/4 of those children became tolerant to peanut between ages 2 and 3, which I think is very reassuring because one of the big questions for Ig-mediated food allergy is persistence of peanut allergy. A different picture has been painted by a cohort study reported from Mount Sinai, where 45 infants with peanut FBIs were identified. And again, they said, prior to 2015, there's almost no cases of peanut FBIs. And most of those infants were male. Most of them had atopic comorbidities. Most of them had ingested peanut at 6 months. His reaction followed several asymptomatic ingestions, and the age was at 6.5 months, and the diagnosis was established by 8 months. And there were classic reactions of vomiting, lethargy, diarrhea, as well pallor. And what was interesting is that the skin testing, so testing for Ig sensitization, was positive in 21%. So this is so-called atypical Ig positive FBIs, but serologic testing was actually positive in 57%. So 57% of those peanut FBIs had atypical FBIs. But only 1 patient with negative peanut skin prick test or IgE at the initial visit actually went on to develop new allergic sensitization and had actually no symptoms of FBIs during subsequent exposures. So there were 14 food challenges to evaluate for peanut FBIs resolution. Majority reacted, so 57, but it's like 50-50. And then all of those infants had typical FBIs symptoms. And the difference was really in the age of the food challenge. So those who were challenged at the median age of 21 and 5 months, median 13.5 months since the last reaction, were more likely to pass. Those were the passing, and those who had positive food challenge, where median age was 52 months with a median interval of 38 months. So it's really hard to know whether prolonged avoidance was associated with more persistent FBIs, or that there was a self-selection in the infants that had more severe initial symptoms. There was more reluctance to reintroduce peanut even under the supervised conditions. Martha Vasquez-Ortiz has done a lot of very great studies in FBIs, and I'm going to cite highlight her recent systematic review and meta-analysis of Ig sensitization in acute FBIS. And there's a large number of studies that were reviewed, but 53 studies were eligible. And there's sort of the evidence in support of connection between Ig sensitization and persistence of FBIS, which has been proposed by earlier studies, that we said, okay, if we see that the patient develops IgE positivity, they're less likely to outgrow their FBIS sooner. Here, there was no clear association. The overall sensitization rate was about 9.8%. So a typical Ig positive FBIS was 9.8 across all of the foods, and the seroconversion was 1.1%. So those who started as negative and then became positive. And the phenotype was equally uncommon. So the switch from the FBIS, classic FBIS delayed symptoms to the immediate symptoms was very rare. And the authors concluded that there's no consistent evidence for the relationship between Ig sensitization and FBIS persistence. Phenotype switch to Ig-mediated food allergy is uncommon in acute FBIS, and Ig sensitization in FBIS does not have a clear relationship with clinical outcomes. So this is the figure from the study. And let me point out something interesting. So these are the egg, nuts, so peanut, tree nuts, milk, and soy, were actually the foods that were associated with higher rates of atypical Ig positive FBIS. And even though this meta-analysis did not show, and systematic review did not show association, not transition to more immediate symptoms, I can tell you that in our clinical practice, as well as in other studies that hasn't been published, but I had the opportunity to review, there was a much higher rate of transition to Ig-mediated symptoms than reported in that meta-analysis. And it was in particular in association with cow's milk FBIS as well as an egg FBIS. So I think this is an evolving story, and stay tuned. And certainly in my clinical practice, I do perform skin testing for patients with, for FBIS infants with egg, milk, and peanut, tree nut to sort of guide me on the procedure, the diagnostic procedure for the food challenge, or how we're going to introduce that food. Comorbidities were also, atopic comorbidities were also reported from different studies, one study from CHOP, another study from Poland, and this is very consistent. FBIS is a part of that atopic and allergic phenotype. And in particular, in that study from CHOP in Philadelphia, particularly Ig-mediated food allergy was really high among infants with FBIS, but to other foods, not to the FBIS food triggers association. So we've noticed that a long time ago that a patient can have FBIS to soy and anaphylaxis to milk, and this is holding true. How do we diagnose FBIS? Unfortunately, we do not have biomarkers, and more recent studies that were trying to really look at some fecal parameters, like looking at fecal EDN or calprotectin or secretory IgA, did not really show association with the outcome of the challenge. But so at this time, FBIS is a clinical diagnosis, relying on the recognition of the constellation of symptoms, like similar to anaphylaxis. And here see the major and minor criteria for pediatric FBIS, which have been proposed by 2017 guidelines, and they will likely be revised when we update the guidelines to account for different presentation in adult patients. And chronic FBIS, as I mentioned, which is mostly reported in infants in the context of infant formula or even exclusively breastfeeding, is really a diagnosis that is presumptive in vast majority of cases, because confirmation with a food challenge after eliminating the suspected trigger, as well as the resolution of symptoms, then a subsequent reintroduction should induce more immediate reactions, and this would actually confirm diagnosis. So emergencies in FVICE are treated different than allergic Ig-mediated allergic emergencies, and we are using ondansetron, so antiemetic, and serotonin receptor antagonist quite freely. In more severe reactions, we do recommend a single dose of steroid because there's a very strong inflammatory, both innate as well as adaptive inflammatory signature. But generally, and rehydration, oral or IV is the mainstay. The injectable epinephrine or adrenaline or oral antihistamines have not been shown to be of benefit in the patients. And obviously, there's a spectrum of severity among the patients, and not every reaction has to be treated in medical facility if symptoms are milder. So here is a proposed emergency treatment plan for patients with FVICE that can be found on fvice.org, and sort of, explaining the differences between FVICE and IgE-mediated reactions, and also providing the doses of medications, etc. So this coming handy because now when the kids are getting older, going to school, and the parents are reporting food allergy, they are expected to provide anaphylaxis treatment plan, adrenaline, as well as antihistamines. In a long-term dietary management, I want to highlight a couple things is that, certainly doesn't seem that avoidance of traces of food is necessary, but be careful with baked milk and egg, although there are studies that show that a subset of patients can actually tolerate milk and egg in the baked form. Those who react may have very serious symptoms. Generally, there's no need to restrict maternal diet during breastfeeding if some baby is thriving. And then hypoallergenic formula may be necessary. Involvement of registered dietitian nutritionist is very valuable, but not always available. And then it's important to monitor growth and introduce solids in timely manner because FVICE can be associated with feeding difficulty. So just to, in the interest of time, I'm not going to go over those in detail, but there are a couple reports that are showing tolerance to baked milk among infants who reacted to non-baked milk during the food challenge, as same with the egg FVICE, and similar to Ig-mediated food allergy, tolerance of baked egg precedes development of tolerance to non-baked egg. And in the study comparing the feeding difficulties reported by caregivers between children and infants with FVICE adjusted for age, there's significantly higher concerns for feeding, problems with oral sensory issues for infants with FVICE compared to Ig-mediated food allergy. When it comes to predicting the severity of future reactions, it's really difficult because, as we say, we don't have a biomarker. In the study from University of Michigan, the only predictor was the severe initial reaction. It's sort of my clinical impression as well. And the severe reaction is, patients who were admitted, treated with intravenous fluids, and those who reacted to a very low dose of food with more severe symptoms. But among those who have milder symptoms than a milder phenotype, the dose of food, if the dose is higher, they may be associated with more symptoms than if they eat a smaller dose. So I'm happy to explain this, elaborate on this later. The challenge protocol is not universally accepted, and it's not straightforward. What we use in the US was usually 0.06 to 0.006 to 0.6 gram per kilogram body weight, but not more than 3 grams, and prolonged observation. But there are other modified FVICE food challenge protocols that have been tested in different countries, and generally the feeling is that most of the patients will react to the lower dose than the one that we've used to recommend. And even to as little as 2% of the serving for age in this Japanese study. So none of those infants who actually reacted to that very low dose were treated with intravenous fluids, as opposed to other kids who reacted at the higher dose. So maybe prudent to implement a different approach with a lower serving size, about 25% of the age-appropriate portion, as outlined in that systematic review, again, from Marta Vasquez-Ortiz group. Clearly, it would be desirable to come up with a sort of standardized approach how to perform those challenges in the optimal way. Generally, for FBIs with infantile onset, prognosis is very favorable, maybe with exception of seafood, that only minority will outgrow it by age 3. But vast majority of other foods are being tolerated by age 3 to 5. And maybe with exception for egg, and now also, the question of peanut and tree nuts as those new triggers. This is data from Sydney, from Summer and Eric Lee, and they noticed that the resolution of egg FBIs tend to occur at the older age. So at this point, there's no there's no evidence approach to FBI's food trigger range reduction. So generally, it's a common sense, how nutritionally important and how socially important it means, like, is child exposed to that food in the daycare, at home, with the older siblings. And just be aware that while most children tolerate the food by age 3 to 5, there are some exceptions, such as fish, shellfish, egg, and possibly peanut and tree nuts. I'm going to refer you, if you're interested, we've published the algorithm for FBIS diagnosis in the Allergy last year. And it's pretty, as you can see, it's a pretty involved algorithm. There's also an algorithm for FBIS management. So this is something that could be a useful resource. So I want to end with my key points that cow's milk still is one of the leading triggers for infantile onset of acute as well as chronic FBIs. Globally, the new triggers for FBIs are egg, or maybe egg yolk specifically, peanut and tree nuts. And then clearly substitute children with milk egg FBIs could tolerate those foods in baked products. If they had severe reactions to cow's milk or egg, the introduction is prudent under supervision. And I still think that patients with atypical Ig positive FBIs it's really impossible to predict what symptoms they will have. So if we challenge them, we are ready to manage both types of symptoms. And the infants that have really severe initial reactions, multiple food reactions, are at risk for feeding difficulties. So it's important to be proactive in introducing solids and supporting the caregivers. And in terms of the oral food challenge, the modified food challenge was 25% of the serving size. Is quite accurate, sensitive, and is associated with lower rate of severe symptoms. And generally, FBIS has a favorable natural history, with majority tolerant by age 3 to 5 years in children with infantile onset. So I'll stop here, and thank you so much for your attention. I'm happy to take any questions later.
That's great talk, Anya. Thank you so much for that. We do have some questions in the chat. The first one is, what is a differential diagnosis between lactose intolerance and FPIES?
Well, I mean, clearly, with the acute FPIES, which accounts for 90% of patients that we see in the allergy clinic, it's very different. It's the vomiting. Like you don't get projectile vomiting and lethargy and pallor and dehydration and ending up in the emergency. At least I've never seen such a severe lactose intolerance. I think the difficulty may be with the chronic FBIs, right? Like if you suspect it, but again, like primary lactose intolerance in infants is incompatible with life. So this is super uncommon. And keep in mind that symptoms in chronic FBIs are progressive. And again, lactose intolerance is mostly diarrhea, but bloating, gas, sort of malabsorption, but not like dramatic failure to thrive in those infants. So these are quite different presentations, and especially if you have a patient who ends up being admitted with hypovolemia, abdominal distension, neutrophilia, methemoglobinemia. This is not lactose intolerance.
Okay, great. I have another question here. It's if the baby is highly reactive to multiple foods, so more than 5, to introduce or reintroduce these foods, and when to trial them. So if there's a lot of foods, when do you think you could start to reintroduce them?
Yeah, so the question about reintroduction, so if they're avoiding multiple foods, then usually have a quite restricted diet. So it is, clinical approach is to start introducing from foods that are unrelated, that have sort of low risk for reactions, and do it gradually and go slow initially and build confidence. Because if, in my clinical experience, if the baby reacted to multiple foods, the parents or caregivers are very kind of reluctant and they're scared and they don't know what to do. So you want to build their confidence, gradually. And with every new food that is being tolerated, the confidence increases. If you start, let's say if baby reacted to oat and then you choose rice as your next solid food for introduction, or wheat, it's probably higher risk of reaction to that food than to, let's say, broccoli or carrots or, something else. So there are some publications that sort of, really have a very empirical, very practical approach. And also keep in mind that some babies, when they react, they totally lose interest in eating. So it's not uncommon that for the next 2 weeks, they will like refuse anything by breast milk, but breast milk. So that's why it's like, it's really a bit of an art to choose the foods that have like the lowest rate of reaction. So this is new food. Reintroduction of the food that caused the symptom depends how bad the symptoms were. I usually wait until we have the other foods introduced because I don't want to have a reaction that will set me back for introduction of other foods. Generally, the consensus is not sooner than 6 months since the most recent reaction. In practice, it usually takes a bit longer because parents don't want to do it, or there are other foods that we're working with, so it takes time. But you could consider 6 months. It's obviously milk is more important than, let's say, sweet potato or corn. But oat is a big deal in the US because there's Cheerios, which is a snack that is everywhere, in the daycare. So there's a lot of those practical considerations.
Great. There are a lot more questions in the chat, but I think we have to move on. But if you do have time,
Yeah.
maybe have a look and see if you can answer
Yeah.
some of those. That's
Okay.
great. Some of them are on adults, however, and of course, they may be better for our next speakers. So thank you so much for that wonderful talk. Thank you. I'm very delighted that we have Dr. Purificación González Delgado speaking to us about adult FPIES. As someone who sees adults, and I have seen some adults with FPIES, I'm really excited to hear your talk today. So please do start your talk now, Dr. González Delgado. Thank you very much.
Good afternoon. Thank you very much for the presentation. I also would like to prepare an academy for this invitation, and I also would like to say I am very honored to share this webinar with Dr. Novak, and also thank you to the attendees, of course. Well, I have no conflict of interest. In recent years, we have been observing an increase in food-related pathology. Especially, we observe a rise in patients who self-diagnose as allergic to foods, reaching up 20% of the adult population. However, the data we manage ranges between 3 to 7%, with the consequences that this implies unnecessary diets and loss of tolerance, with increased risk of IgE-mediated reactions to foods previously tolerated. And these facts are more common in non-IgE-mediated reactions. Well, when we study non-IgE-mediated food allergy, we have some problems. The first is we don't know the prevalence, and otherwise the diagnosis is clinical and not always easy because we don't have specific biomarkers. So diagnosis is based on compatible symptoms, exclusion of other causes, remission after food withdrawal, and recurrence of symptoms after reintroduction of the implicated food. How do we diagnose non-IgE-mediated food allergy? Well, the most important tool is the clinical history, but sometimes the clinical history is non-conclusive. So we have to perform another food challenge that remains as a gold standard for these conditions. As we don't have another specific procedures because we don't know the pathophysiology of these conditions. From now on, I'm going to focus in food protein-induced enterocolitis. Well, the first cases of FPIES were reported in the 60s. Since then, a growing interest has been observed in the literature, reflected in the high number of publications, as you can see. But it was not until 2012 when the first case of an adult FPIES was reported in the UK by Dr. Fernandez. It was a 53-year-old man that after eating a scallop reported vomiting, diarrhea. Later, in 2014, Dr. Tan in Australia reported a case series of 31 adult patients with a syndrome characterized by acute, isolated gastrointestinal symptoms without other manifestations. This syndrome shares some similarities with infantile FPIES, but she didn't report it as FPIES because since until then, the disease was considered exclusive to the pediatric population, but she highlighted the role of some foods and noted a clear female predominance. So the question arises, is FPIES possible in the adult population? Later, new series appear in the literature. For example, this one by Jennifer Du in Canada is a series of 25 adult patients. Later, we reported this series of adolescents and adults with diffuse FPIES. And in these publications, the existence of food protein-induced enterocolitis is recognized in the adult populations and is considered a disease not exclusive to the children population. But what are the clinical features of FPIES in the adult population? Well, as you can see now, we have more information. There are new case series. Here I have gathered the different series reported to date. And as you can see, abdominal pain and diarrhea were the most common manifestations in the adult population. And vomiting was absent in up to 25 or 30% of the adult population. So we have a diagnostic problem. Vomiting is the major diagnostic criteria in the international consensus for FPIES. So a high percentage of patients wouldn't be diagnosed with the current criteria of the consensus. So some authors have proposed revisiting the criteria for FPIES in the adult population. Here I have represented the different symptoms in the largest series. As you can see, abdominal pain, diarrhea, and vomiting are the most common symptoms reported. However, I would like to highlight that in the adult population, lethargy, chills, and hypotension are also present, but they are not so common like in the pediatric population. For example, dehydration and metabolic changes are uncommon in the adults, unlike the pediatric population. And these are data from our cohort of 107 patients. As you can see, a clear female predominance with a median age at first reactions of 30 years. And we have a diagnostic delay of 4 years with a median of 8 episodes before the patients were diagnosed. So this means we have a significant diagnostic delay due to sometimes patients don't seek medical attention, or sometimes due to a misdiagnosis because a lack of awareness of this condition. Continuing with our patients, as you can see, 40% of our patients needed treatment in emergency department. However, these rates are lower than in the pediatric population. And respect to the topic, our population report had around 60% were atopic, like other series. Regarding the triggering foods of adult FPIES in our series, as you can see, crustaceans, felids, bivalves, and cephalopods were the mostly implicated food. However, in those series, shellfish was important, but dairy, wheat, and egg were also important triggers in the adult population. In our experience in the last years, any food can trigger FPIES, even foods that are usually not implicated in AGE-mediated reactions. Perhaps this means the emergence of new sensitizations or a greater awareness of this condition in the adult population also. Well, as Dr. Novar said, with respect to the prevalence in the adult population after a survey performed by Dr. Novar, Bayania, in 40,000 patients, the prevalence estimated in the adult population was 0.22. This means that a high number of patients may suffer from this condition, but we don't have data on our country or on our patients. The natural history between both populations seem different. The data in the adult population are limited. However, in our experience, in our prospective study, after a median follow-up of 6 years, we observed that 70% of the adult population achieved tolerance and 10% improved the tolerance to the triggering food. However, in those first 4 years, 20% of the adult population achieved tolerance. So perhaps the prognosis is not so bad as the first years we suspected. Here I have summarized the difference between both populations. As you can see, a clear female predominance in adults. The triggering foods obviously are different due to different dietary patterns, but I would like to highlight that fish is also an important trigger in older children. We saw that symptoms differ with a sense of vomiting in a high percentage of the adult populations, and respect to the severity. In our experience, the adult phenotype is milder than the children phenotype. In our experience, and we have been performing oral food challenge for the last 12 years perhaps, the adult phenotype is milder in most cases than the pediatric child. In the first years, we started performing oral food challenge in children, and we had very severe cases. However, in the adult populations, I don't remember severe cases. Respect to the natural history, as I said before, less favorable in the adult population. Well, and I would like to talk briefly about a special subgroup of adult patients that are patients with multiple food FIs. These patients usually refer to chronic abdominal pain or recurrent diarrhea. Sometimes they have emesis. So they are referred to the gastroenterology service, where multiple exploratory procedures are performed. For example, they rule out sugar intolerances, they rule out high Helicobacter infections, SIBO, they perform sometimes colonoscopy and endoscopy, and sometimes they are labeled as IBS, irritable bowel syndrome. Sometimes these patients are referred to our allergy department, and in these cases we perform a careful clinical history, and we recommend completing food diary. And if we have some suspected foods, we perform an oral food challenge. If the oral food challenge is positive, we remove the food from diet, and if the patient improves, we finally label them as food protein-induced enterocolitis. And this happens usually in patients in which the F is implicated. In FIs, we observe different profiles from patients that don't tolerate traces to others that tolerate different presentations. So a high index of suspicion is needed in FIs. Well, in this Pandora's box that represents IBS and irritable bowel syndrome, perhaps a small number of patients may suffer from multiple food protein enterocolitis. However, the number of patients in our series was too small to establish a conclusion. In this algorithm, we aim to simplify the diagnosis of adult FIs. So when we have a patient with a suggestive clinical history, due to the inspecificity of symptoms and given the absence of vomiting, we think that the clinical history should be followed up by an oral food challenge to avoid misdiagnosis, overdiagnosis. So the oral food challenge would have a value to diagnosis and also helps assess disease resolution of the disease. We usually recommend to perform an oral food challenge every 2-3 years. And after perform an oral food challenge in the hospital, sometimes the patient pass the oral food challenge. However, we recommend a 30-day follow-up because sometimes patients have symptoms with the second or third reintroduction at home. Well, differential diagnosis of adult advice should be done with many gastroenterological conditions, for example, with SIBO, inflammatory bowel disease, irritable bowel syndrome, sugar intolerances, eosinophilic gastroenteritis, etc. So we think that the collaborations between gastroenterologists and allergologists is very, very important for these patients. And in the second part, I would like to talk briefly about diagnostic biomarkers in FIs. As I said before, the only diagnostic tools we have are the clinical history and the food challenge. However, in recent years, we have gained insights into the pathophysiology of FIs, leading to promising results toward identifying a useful biomarker. And for example, animal models with allergic enteritis have been developed in recent years that might provide useful information about this condition. Otherwise, the different omic techniques, genomics, transcriptomics, proteomics, are providing very useful results, as we are going to see now. Well, as I said before, we don't have useful biomarkers in clinical practice. However, we use some blood biomarkers and test fecal biomarkers that can help in diagnosis. With respect to the blood biomarkers, their usefulness is limited in the clinical practice. However, we know that after an oral food challenge, the neutrophil count increase, especially in the pediatric population. With respect to the CRP and tocilizumab, their use is more controversial, but they may be useful to rule out other conditions. For example, in the pediatric population, they may be useful to make the differential diagnosis between sepsis and FIs. In this recent work by the BioFIs group, they aim to know if there was a clinical correlation between clinical symptoms and hematological change. And they report that an inverse correlation they observed between the increase in neutrophils and the severity of the clinical picture, with a higher increase in neutrophils in patients with less severe symptoms. What happens in adults? In the few studies in the adult populations in which an oral food challenge was performed, an elevation in neutrophils was observed in approximately 50% of the adult population, with milder increases in the neutrophils than in the pediatric population. Well, here I have greater potential biomarkers reported in different work. Perhaps they may be useful in next years. For example, in this work by Mer, they aim to better know the physiopathology of FIs, and they reported that after performing oral food challenge in the pediatric population, they observed an increase in gene and activations in genes related with innate immune system. They observed an activations of genes related to metallopeptidasas with IL-1 beta, ICAM, phosphorestat. Perhaps some of them may be useful in this year to help for diagnosis. And in this important work by Dr. Bering, Cecilia Bering, they also performed oral food challenge in pediatric populations, and they observed that in the active group, there was an increase in IL-17 family cytokines. They also report an increase in innate inflammatory markers, for example, IL-8, IL-6, IL-10, TNF-alpha, etc. What happened in adults? Well, in our population of adult patients, we performed oral food challenge in 50 patients, and we observed that in active group, there was an increase in IL-6 and an important increase in IL-17. These findings are very important for us because they suggest a common mechanism between both populations, between the children and the adults. The metabolomic techniques are also providing useful information. For example, in this work by Dr. Lozano-Halbo, Daniel Lozano-Halbo, they report an activation of the cholinergic pathway in children after oral food challenge. They observe an increase in 34 metabolites that are also maybe helpful for diagnosis and to better understand the pathophysiology. This work, again, by the BioFIs group, they try to better understand the physiopathology, and they observed that after oral food challenge, there was an activation of genes related with epithelial barrier integrity and also genes related with immune dysfunction. So they conclude that perhaps F5 has a genetic basis. Respect to the fecal biomarkers, as I said before, their usefulness is limited in clinical practice. Some of them are being used currently, for example, calprotectin, EDN, secretory IgE. Summary, I would like to highlight this interesting work by Lemoine in France. And in this work, they performed oral food challenge in an active group of children. And they observed that after oral food challenge, there was an increase in fecal calprotectin. This increase persisted for 5-6 days. But when the patients were asymptomatic, no gut inflammation was observed in these patients. However, in asymptomatic patients with active F5, there was an increase in IgE. So they report that perhaps IgE, secretory IgE, really useful to predict the outcome of oral food challenge, and they may be useful to diagnose perhaps F5 without needing to perform oral food challenge, but the results must be confirmed. What about the adult population? Well, in this small cohort by Aranchuela in Spain, they performed oral food challenge in a small population of patients, and they observed also an important increase in fecal calprotectin. And finally, in this work, we studied the microbiota signature in children in our hospital a few years ago, and we observed an increase in some species and a decrease in others. For example, we observed an increase in Lactobacillus and a decrease in Lactobacillus. So a different microbiota signature is observed in children. Now, in the last year, we have been studying the microbiota in adult population. These results are preliminary. We have to work harder with them. But we observe that in adult population, there is a different microbiota signature compared with non-atropic controls. Concluding, we can say that an increased awareness of adult F5 is essential to improve recognition and diagnosis. Oral food challenge remain the gold standard to confirm diagnosis, and systemic innate immune activations and Th17 family cytokines play a key role in the pathophysiology. However, further research is needed to validate potential biomarkers. And this is all.
Lovely. Thank you so much for that wonderful talk. Really interested to hear about the biomarkers and the calprotectin, because that's quite an easy thing to measure, isn't it? So I think that's going to be really helpful going forward. I know there's been a lot of questions in the chat, but Professor Novak Venjan has been very assiduous in answering a lot of them. So there's something I would very like to know, and that is whether you think these biomarkers particularly could be validated to diagnose FPIES without doing a challenge, and would you recommend a challenge for every patient where you suspect FPIES? Because as you said, it often gets very confusing with other conditions like irritable bowel syndrome, etc. So just about the biomarkers and also challenge.
Well, currently we don't have any useful biomarkers that can confirm diagnosis. We need to perform oral challenge. There is some groups studying this subject, and perhaps in a few years we'll have biomarkers. However, today the only available biomarker perhaps maybe neutrophils with oral challenge. And the results by Lemoine, I think they are very interesting. And perhaps the secretory IgE may be useful without needing to perform another food challenge. The immunological potential biomarkers, I think we need more time to confirm. For example, I'm 17 family, but we are in the same situation. We need to perform oral food challenge. So by now, we don't have any specific biomarkers without performing oral food challenge.
Thank you. I have a question here in the chat. It says, in an adult with egg-induced FPIES, this has not resolved in 5 years. What should the management approach be to induce tolerance to egg with lower heat processing? So is there a chance of future tolerance if the oral provocation test is still positive at the 7-year follow-up? So what about the long term for these patients? What do we know about resolution, and also how can we then manage if it's egg FPIES? Is it worth trying baked egg or other kinds of egg?
Well, we don't have experience with baked egg. There are only 2 studies in Japan that they are trying to develop tolerance. However, we don't have any test now, any tool for developing tolerance. But in patients who have developed tolerance, they continue taking the foods, we have no problems. But I think the try to develop tolerance is hard. We have more studies. It's difficult to induce tolerance.
Okay, so we definitely need more data, don't we, around the world for adult FPIES to understand tolerance as well. So somebody else has asked is there a different food challenge protocol recommended for adults, or could you use the same one that you might use for children?
No, there is no consensus about the oral food challenge. I can talk about our protocol.
Yes.
Due to the adults have more working problems, etc., we perform the oral food challenge in one morning. We administer 25% of the AAT, and 2 hours later, we give the rest of the dose. This is more practical because laboral problems in the adult population. However, in the pediatric population, perhaps the most useful and secure protocol is to divide the doses in 2 days.
Okay, so will there? It says, will there be any specific signs in the biopsy examination obtained during colonoscopy in the case of FPIES? So would you do a biopsy, and if so, would you find anything from that?
Well, there is not enough information. We don't have too much data, but in 2 or 3 reports in the biopsy, there is an increase in mastocytes, eosinophils, neutrophils, and there is not enough data, and we don't have data in adults.
Okay, so I think the key message is we need more data. So if you're listening, please start collecting it, and it would be great if we could come to some consensus about how to manage that. So, well, thank you very much for that talk, and for both our speakers. It's been a wonderful session. We've had nearly 300, so we had 276 people join online, but I know we had over 1,000 people who signed up, so I hope lots of those people will be listening to this talk online afterwards. So I just want to thank both our speakers for giving a great overview on both FPIES in children and adults. And thank you so much to all of you for participating and all of your questions. Thank you very much.
Thank you.
Thank you.